Bismillahirrahmanirrahim. In this lecture, we will discuss the different head and neck spaces and their abscesses. In the head and neck region, there are different types of spaces which may act as potential spaces in which the abscesses may develop and they cause symptomatology. These different head and neck spaces are parotid space, peritonsillar space, submandibular space, retropharyngeal space, prevertebral space, and parapharyngeal space. First, we will discuss the parotid space and its abscess, that is the parotid abscess. Parotid space lies deep to the superficial layer of deep cervical fascia. We know that this deep cervical fascia spreads into two layers, superficial layer and the deep layer. Parotid space encloses parotid gland and its associated structures. In this figure, you can see the parotid gland which has been exposed by removing the overlying superficial layers, skin, and fascia. Parotid abscess. Parotid abscess is the suppuration of the parotid space. As we know, superficial layer which is very thick while the deep layer is very thin. Because of this thin deep layer, the parotid abscess may burst deeply to form the parapharyngeal abscess, and then it may spread to the mediastinum. Etiology of parotid abscess. In majority of the cases, it is the surgical trauma to the parotid gland which may lead to parotid abscess formation. Infection from the oral cavity via Stensen's tract, dehydration in post-surgical cases of parotid gland. Sometimes if the patient is having some sort of debilitated condition. Similarly, sometimes there are multiple small abscesses formed within the parotid gland parenchyma, which may coalesce to form a single abscess. Microbiology. In majority of the cases, it is the Staphylococcus aureus which is the most culprit microorganism forming the parotid abscess. Anyhow, other important microorganisms which may contribute to parotid abscess are streptococci, sometimes some anaerobes, and even gram-negative microorganisms in the form of E. coli may contribute to some extent to form the parotid abscess. Clinical features. Usually, they appear 5 to 7 days after the parotid trauma or parotid surgery. The patient will have swelling of the parotid region, redness of the parotid region, fever, pain, tenderness in the parotid region, fluctuation rarely found due to thick capsule. Opening of the parotid duct is congested when we examine the parotid opening in the oral cavity, and sometimes if we press the parotid gland from outside, we may see exudative discharge from the duct opening coming out from the opening of the duct of the parotid gland. Diagnosis is made by history, examination of the patient, and investigations. Investigations, important ones to diagnose are ultrasound examination of the parotid gland, CT scan of the parotid region, and FNC of the parotid swelling. Treatment. First of all, correct the dehydration of the patient. Then improve the oral hygiene, promote salivary flow, and start injectable antibiotics, especially For example, Dalacin C containing clindamycin. Then symptomatic treatment in the form of analgesics. Then definite treatment, that is the incision and drainage of the parotid abscess. Keeping in mind the branches of the facial nerve, the incision is given parallel to the branches, not across the branches of the facial nerve. Second important space is the peritonsillar space and its abscess, that is the peritonsillar abscess, also named as quinsy. Peritonsillar space. This space lies between the capsule of the tonsil and superior constrictor muscle of the pharynx, which forms the bed of the tonsil. Peritonsillar abscess forms when there is collection of pus in this space. In this figure, you can see the abscess formation in the right peritonsillar space. Peritonsillar abscess or quinsy. It is the collection of pus in the peritonsillar space. Usually, the etiology is the acute tonsillitis. Sometimes intratonsillar abscess bursting through the tonsillar capsule and setting up peritonsillitis, and then this peritonsillitis may change into abscess formation. Usually the victim is an adult, rarely a child may be the victim of the quinsy. Microbiology, mostly the mixed microorganisms, that is both gram positive and gram negative microorganisms may be involved to cause the peritonsillar abscess. But both aerobes and anaerobes, similarly Staph aureus, Streptococci pyogenes, and in quinsy may be involved to cause the peritonsillar abscess. Clinical features. As I have said, mostly adults are the victims, but rarely the children may be affected by this disease. Usually the peritonsillar abscess is unilateral, but it may be bilateral, rarely. The usual symptoms are the local symptoms in the form of severe pain in the throat, usually which is unilateral. The patient will have rhinophagia, muffled and thick voice, that is the hot potato voice. The patient may have foul breath and ipsilateral earache referred, this is called referred pain via the ninth cranial nerve. The patient sometimes may have trismus due to spasm of the pterygoid muscles as well. The patient, apart from local symptoms, he may be having general symptoms as well in the form of fever even up to 104 degree Fahrenheit. The patient will have chills and rigors, malaise, body aches and pains, headache, nausea, and vomiting. Signs on examination. The patient will have congestion and swelling of the affected tonsils, pillows, and soft palate. Uvula will be swollen and it will be edematous as well, and it will be pushed to the opposite side. Bulging of the soft palate and anterior pillar above the tonsils. Sometimes mucopus covering the tonsillar region is also seen. Duodecitic lymph nodes are enlarged and they are tender as well. Sometimes the patient may have torticollis as well. Diagnosis. Usually the diagnosis of peritonsillar abscess is a clinical one. No difficulty in diagnosis should be there. Anyhow, if there is a doubt about whether it is a peritonsillitis or peritonsillar abscess, then you can just take a whiteboard needle and aspirate the abscess. If the pus is coming out, or it is then it is peritonsillar abscess, or if there is no pus aspirated, then it means the patient is having peritonsillitis. Treatment. Treatment of peritonsillitis. First of all, the patient should be hospitalized. He should have IV line and IV fluids should be given to the patient. And then injectable antibiotics covering all possible microorganisms, gram-positive, gram-negative, and anaerobes should be given in the form of, for example, injection augmentin plus injection flagyl. Analgesics should also be given and improve the oral hygiene as well. If the patient is having peritonsillar abscess, then apart from all these measures, he will have to be given other sorts of treatment as well. For example, the surgeon may aspirate the peritonsillar abscess with a wide bore needle or cannula. The important and precise treatment for peritonsillar abscess is the incision and drainage of the abscess. Similarly, the patient may be offered interval tonsillectomy, that is 6 to 8 weeks after the attack of Kinsey's. Similarly, the patient may be offered hot or abscess tonsillectomy. In this case, there is no incision and drainage of the abscess. Rather, tonsillectomy is performed straightforward. But there are certain risks when surgeon performs hot or abscess tonsillectomy. For example, there is a risk of rupture of the abscess during anesthesia when the anesthetist performs intubation. Similarly, in hot or abscess tonsillectomy, there is excessive bleeding during surgery because of active infection. Now, as I have said, the actual treatment for quinsy or peritonsillar abscess is the surgical treatment, that is the incision and drainage. The question arises where the incision should be given, how the incision should be given, and with what the incision should be given. The answer to the first question, where the incision should be given. The incision should be given at the most fluctuating and bulging point of the abscess. And where the incision should be given? First, you draw two lines. One at the junction of a horizontal line running through the base of the uvula and another vertical line running along the anterior tonsillar pillar. The point of transection of these two lines is the point of incision and drainage. Site of incision for quinsy on the left side is shown in this figure. You can see the two lines, one running to the one horizontal line running to the base of the uvula, the other line, that is the vertical line, passing or running through the anterior pillar of the left tonsil. And the point where these two lines they intersect with each other is the site of incision of for quinsy. How the incision should be given? The incision should be given in sitting position without any anesthesia. With what the incision should be given? The incision may be made with quinsy forceps or with the help of a surgical blade number 11 with open tip, the remaining part of the blade covered with sticking plaster. Complications of quinsy. If the quinsy is not drained or it is not treated well, then it can produce certain complications. Although these days the complications of peritonsillar abscess are very rare because of the modern antibiotics. Anyhow, the complications which may occur due to quinsy are parapharyngeal abscess, laryngeal edema, pneumonitis or lung abscess, jugular vein thrombosis, and spontaneous hemorrhage from carotid artery or jugular vein, which may prove fatal and may cause death of the patient. This figure is showing you the right-sided peritonsillar abscess. The uvula is deviated towards the opposite side due to this huge peritonsillar abscess of the right tonsil. This is the axial view of the CT scan of the oropharyngeal region showing the abscess formation in this area. Abscess of the right peritonsillar abscess. Now this figure is showing you the pus aspirated with the help of a wide bore needle. This repeated abscess aspiration sometimes may act as a treatment for the quinsy. The next important space is the submandibular space and submandibular abscess formation. Submandibular space lies between the mucous membrane of the floor of mouth and tongue on one side and superficial layer of deep cervical fascia extending between the hide bone and mandible on the other side. This submandibular space is divided into two compartments by mylohyoid muscle. One is the sublingual compartment, which lies above the mylohyoid muscle. The second is the submaxillary and submental compartment, which lies below the mylohyoid muscle. Now, this figure of the neck shows you the two important abscesses, or two important regions rather. One is the submental region, the second is the submandibular region. This is the photograph of a patient. You can see the edematous neck with edema of the face as well and tracheostomy in situ. Ludwig's angina. Ludwig's angina is the spreading cellulitis of the submandibular space, that is sublingual space or submental and submandibular regions or both. Usually it is just cellulitis. Frank pus or abscess seldom forms in this disease. Etiology. In about 80% of the patients, it is the dental infection which is responsible for Ludwig's angina. From anatomy, we know that roots of the premolars, they remain above the attachment of the mylohyoid muscle, and so they cause infection of the sublingual space only. On the other hand, the roots of the molars extend up to or below the mylohyoid line, so they will cause submaxillary space infection. Apart from dental infections, the other certain infections may also lead to Ludwig's angina. For example, submandibular adenitis, trauma to the oral mucosa, fracture of the mandible. Now, this figure you can see that this is the mylohyoid muscle which is attached to the mylohyoid line of the mandible, and this is the molar tooth. You can see the root of the molar tooth is below the mylohyoid line or mylohyoid muscle attachment. Therefore, the root infection of this molar tooth, this will cause abscess formation in the submandibular or submaxillary region. Whereas, if this infection was due to the premolars, as the premolars they do not reach the mylohyoid muscle, therefore that will cause infection of the sublingual region of the oral cavity. That's why that will be more causing symptomatology in the oral cavity. This is typically the abscesses formed in the submandibular region causing submandibular abscess. Bacteriology. Both aerobes and anaerobes microorganisms may be responsible for this abscess formation. Both gram-positive and gram-negative microorganisms. The usual bacteria involved are Staphylococci, alpha hemolytic streptococci, bacteroids, H. influenzae, E. coli, and Pseudomonas. Clinical features. The clinical features depend upon the which compartment is involved in abscess formation. If the abscess forms in the sublingual region, that is, if the patient is having sublingual space abscess, then the patient will have swelling in the floor of mouth. He will have tenderness in the floor of mouth. Tongue will be pushed up and backwards, dysphagia and trismus. If the patient is having submaxillary abscess, then the patient will have these clinical features. There will be swelling in the submental and submandibular regions. There will be tenderness in these regions as well. Woody hard feeling of the regions on palpation. The tongue will be pushed up and backwards slowly, and so it may compromise the airway. Sometimes laryngeal edema may develop, so again compromising the airway. Now, what are the signs of airway compromise or respiratory distress? The signs are movement of the ali nasal, working of the sternomastoid muscles, and working of the intercostal muscles. Treatment. Treatment is number one is the hospitalization. Second, maintain the IV line, give IV fluids and injectable antibiotics covering all possible microorganisms. That is, the triple regime is started. Analgesics should be given to cover pain and fever as well. Then sometimes injectable steroids may be needed. If no response with medical treatment, or if the patient is having airway compromise, then surgical treatment is given to save the life of the patient. Surgical treatment. First of all, if the patient is having airway compromise due to laryngeal edema, pushing of the tongue upwards and backwards, then save the life of the patient by performing tracheostomy. Second, if the patient presents with sublingual space infection, then incision and drainage of the abscess through the intraoral route. And if the patient presents with submental and submandibular abscess, in that case, then incision and drainage is done externally through the cervical route. The incision is given from one angle of the jaw to the other and open it vertically with artery. Complications. Complications due to this disease may be one is that spread of infection to the parapharyngeal and retropharyngeal spaces and then to the mediastinum. The airway obstruction due to laryngeal edema or swelling and pushing back of the tongue. The patient may develop septicemia and aspiration pneumonia as well. The end. Thank you so much for attention.